Good evening and welcome to tonight's DMH DDSUS Fireside Chat. How Inclusion Connects is Making a Difference. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call. American Sign Language interpreters and closed captioning options are available. The American Sign Language interpreters for tonight are Danette Steelman Bridges and Susan King Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Tonight's agenda topics include introductions and a discussion about how Inclusion Connects is making a difference. We will also answer questions submitted in advance of the webinar. At this time, I would like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Gina. Hello, everyone. Welcome. I'm going to take my time a little bit because I know we're kind of after hours and some people are just trying to get home and there's bad traffic right now. And I just want to make sure we have lots of time for the meat of today's conversation. But let me start by introducing myself, and then I'm going to turn things over to Ginger and Tina so they can introduce themselves. Hopefully you know us, but if not, it's great to meet you. So let me tell you a little bit about me. My name is Kelly Crosby, and I'm the director here at our division. It's a long title: Mental Health, Developmental Disabilities, and Substance Use Services. Our division is also responsible for the public system of services and supports for people with traumatic brain injury and also problem gambling. So most of you know us, but some of you don't, but I'm really glad that you're here tonight. So I've been here, the division director. It'll actually be 3 years in December. I'm not sure where that time went, but I tell people, honestly, it's the best job I ever had. I've been at the department now, it'll be close to more like 15 years at this point. And actually, I spent the majority of that time at the department at Medicaid. So I know Medicaid really well. And I'm a licensed clinical social worker and I'm a person with lived experience. So I do what I do because it's important to my family, it's important to my community. And so love what I do. And I'm going to turn things over to Ginger Yarbrough to introduce herself.
Hey, my name is Ginger Yarbrough. I am the Chief Clinical Officer of IDD, TBI, and Olmsted here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I started many, many years ago as a direct support professional working with individuals with IDD and have moved throughout the system in my career as a care manager and in quality management at a tailored plan. And I came over to the division in March of 2023. So right at 2.5 years, and agree with Kelly, this is the best job that I've ever had as well. And I will hand it over to Tina.
Hey folks, I'm so glad that everybody could join us today. My name is Tina Barrett, and I am the Assistant Director for IDD and part of the IDD, TBI, and Olmsted section over here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I have a master's in psychology and I'm a licensed psychological associate. I have been working in the field of IDD for more than 30 years. There's a rule that when you hit 30 years, you get to just call it more than 30 years. The majority of my experience has been in clinical work. I did accidentally start in this field as a direct support professional because it was something that was just required as part of my schooling. It was one of the best jobs that I ever had, and I totally loved it. And then I've worked in a variety of different settings. I've worked in the state developmental centers. I've worked in group homes. I've worked in SCS services, which is the specialized consultative services for those that recognize that. And so for more than 30 years, and then 2 years ago, 2.5, a whopping 1 week before Ginger moved over, I moved over to the job that I'm in now. And I love this, and I'm really glad that I had the opportunity to do that. So I'm going to hand it back to Kelly.
All right, thanks, Tina. So tonight, I'm going to set the stage a little bit, and we can actually, can we take the slides down? I think we're going to do that. Okay, let's take the slides down a bit. Okay. So tonight, we're going to talk about our Inclusion Connects program, but I'm going to let Ginger and Tina explain that. I'll just leave that right there. I get to ask, this is wonderful. I get to ask questions and Ginger and Tina get to answer them, which is like really fun for me, but also I'm grateful because they are truly experts. And one of the cool things I really, really like about Ginger and Tina is I learn something new from them every day. They've been in this field for a very long time and I love learning from them. So I get to ask them questions, but a couple things I just wanted to kind of do overarching before we talk about Inclusion Connects. First, I want to thank you again for joining us tonight. And I want to say that I want to cover this right up top because it's not actually part of our presentation, but I know it's on a lot of people's minds. So the General Assembly's in town. We just met with the Joint Legislative Oversight Committee today. Obviously, Medicaid was a big topic of conversation, but we also were asked to come and do a presentation on the waiting list for innovations. So we were able to talk about that as well, advocate for more slots, but also talk about some of the other services and what we want to do to make the waitlist experience actually better. So people get outreach, education, they get into services, but also we have a better understanding of people on the waiting list so we can design additional services and supports and advocate really in the General Assembly in a smart way with data. Medicaid, of course, covered all the Medicaid things it always does, the Medicaid budget and the rebates and everything else. And I know right now is a bit of a hard time for everybody because for a couple reasons. One, the Medicaid rate cuts have gone into effect. And I know that's really hard for a lot of folks. It's also kind of discouraging, I know, because, because of your really, really extraordinary advocacy, the General Assembly increased direct support professional wages. And so it's really hard now to have a rate cut. It's very hard. And we are watching carefully and we want to hear from you. I know that Tally and the DD Council have done a survey and collected data. I got to talk to Marjorie and Chris and John today about the impacts already to access to services and the availability of providers. So want to hear that information and want to say that we care very much about that impact. And I thank you for your advocacy to the General Assembly. Keep it up. We hope we get a budget increase. We really hope, and that Medicaid is able to reverse those rates. But please keep up that wonderful advocacy work at the General Assembly. It is much appreciated. So we know that's kind of heavy on people's minds. But the other thing we know that's heavy on people's mind is the federal shutdown. It's quite worrisome. So I do want to assure you about a couple of things right now. So even during the federal shutdown, the Medicaid program continues to run. And also the funding that we get at our division continues to come in. So I can't say that is the same for all of the programs of the department, but Medicaid, which is incredibly important to us, continues to be funded. Our state dollars for our public system continue to come in, and our federal dollars for our public system continue to come in. And we haven't had any furloughs at our agency either. So I know those are heavy things, but I wanted to get them off the table up front. And I'm ready. You ready, Ginger and Tina, to dive in? Okay. Today is about information sharing. It's about answering some of your questions. And we thank you for those questions because it's a real opportunity for us to hear what's on your mind and to kind of tailor this fireside chat to some of the things that you really want to know about. And dare I say, it's also a little bit of a celebration, which is hard in these times, but it's a celebration because I think despite it all, right, there's been some tremendous accomplishments in the past couple of years. And you should be proud of that. And I'm proud to work with you every day. So, ready? Here we go. All right. I'm going to start with a barrage, y'all. Ready for this? All right. I want to just have you guys in your own words explain. What is Inclusion Connects? What is it? Why do we have it? Why should anybody care about it? Why should anybody know that name, Inclusion Connects? What's it mean? What types of things are included? But most importantly, how does it actually help people? Is it just a catchy slogan? Does it actually help people? Over to you guys.
All right, so I'm going to kick us off. So one thing that you're going to hear as we're talking through all of this is you're going to hear a lot about choice and supporting people to make the best choice for themselves. So that's really at the meat of what Inclusion Connects is. We want to make sure that people are empowered to make those decisions. And it's the term for the entirety of our public IDD services system. So this is across departments, across divisions. When we talk about Inclusion Connects, it means anyone with IDD, regardless of age, their skill level, for lack of a better word, their choice of living arrangement or choice of employment. DD is a lifelong situation, and it requires a combination of services and supports across the lifespan. And just like anybody else, the needs change from birth through aging. So we want to make sure that we're helping connect those supports across the lifespan as well. And really, some of our biggest efforts right now have been around educating, training, providing toolkits, and doing presentations so that people better understand the system. It is complex. Kelly, you know, you've been in this North Carolina, and we all still have questions. I did care management for years and always had more and more questions. And the system continues to get more and more complex. So we want to try to simplify it and put it in easy to understand terms so that people have the right words, the right understanding to get the services they need from the right people. So you're not calling 15 different places. You can actually get to the right person quickly and easily, and ask questions so you know what you're getting. And then also to be the source of truth. If you've ever Googled IDD in North Carolina, you're going to get a million different websites with old terms, new terms, potential terms, proposed terms, and ideas. And we want this to be the site where you know you can go and get the most up-to-date information, and it's correct. You don't have to question it. We vet everything through our sister divisions. We vet everything that we put on there through our providers and the community as well. So we want to make sure that it's correct when you go there, and we review it. We don't just let it be static. So another thing is, yes, there through awareness, that does mean more people are getting added to the innovations wait list. So you're going to see the wait list continue to grow over time. But that also means with this new awareness that more people are getting services as they wait. But if they're also finding out about the wait list, they're finding out about 1915I services. And we've actually seen that over the last year. There are about 21% more people getting 1915I services since this time last year, which that's a big jump. And when we say getting services, that means they have billed for a service. So not only did they get the assessment, go through the approval process, but they have a staff person that has worked with them to do 1915I services. And that's a big accomplishment. And part of the reason that it's possible is because of the work that Tina's team has been doing around supporting the workforce. And I'm going to hand it to Tina to take care of that.
So I know Ginger keeps wanting to give me credit for it, but I'm going to say that this really belongs to my team. My team has worked so hard to stand up the work around the workforce. Direct support professionals, we all know, are underpaid. There's high burnout. There's a lot that's happening in that space. So through Inclusion Connects, we do have a direct support professional workforce plan that was implemented. It was actually started in 2024. We recently updated that again as part of the work that we're doing in that space. We have launched 2 rounds of funds that are initiatives for recruitment, retention, and training. The first round has actually been sent out through allocations. So those funds are flowing into the community, which is we're really excited about. Round 2 has hit a small snag because we are working to leverage some match funds that we're able to attach to through our partners over at Medicaid. And we want to make sure that we're meeting all the criteria that we need to be able to get those funds and not have to pay anything back. We are also standing up the advanced DSP training courses at 3 of the community colleges. So those are currently available at AB Tech, Stanley Technical College, and Forsyth Technical College. All 3 of those classes have started. They are full and they have wait lists, which we're really excited about. They're currently available at no cost. So I encourage folks that are interested to sign up for those. And we are working to develop a scholarship program so they will continue to be at no cost for direct support professionals who are interested in pursuing advanced degrees, because those courses, as part of a DSP certification program, will eventually feed into an associate's program as well. So we're really excited to be able to stand that up. We're also looking at a training incentive, a bonus for the staff who complete those courses. So we're looking at not only bringing people into the field with intention, but also being able to provide good services, ensuring that they have high quality skills and that those skills are portable between agencies, which is also something that's really important, is making sure that a person can move between agencies if that's something that they need to do.
All right, so Ginger, I'm going to go back to you for a second. All right, so if I summarize what you said, so Inclusion Connects is the overarching name for our initiative, right?
Yes.
You mentioned access to services. Tina mentioned a strong workforce. And I know those are the three parts. We'll talk about the third part later, right? Okay.
Yes.
So it's the name of the initiative. I'm just making sure I get this right. It's the name of the initiative, but it's also a website home where people can go to find up-to-date information, because our system can be super confusing and we want it to be a source of truth for people. Am I saying that right? Okay.
Yes.
All right. And Tina, direct support professionals. Can I ask you a hard question?
Ask me a hard question.
All right. Because I got asked this today. I'm going to pass it on and pass the love on to you. So, how will we know that we have more direct support professionals? How will we know?
It's a great question. So part of what we're tracking is what we're calling, it's the utilization rate. So, and we're looking at CLS services, which is community living and supports. Those are services that are typically provided by direct support professionals. And so we are looking at the number of hours that are authorized as a part of a person's plan and the number of hours that are billed, with the assumption that those are primarily provided by direct support professionals. The plans, the health plans that we work with, that we're contracted with, have an 85% what we call utilization rate. And we did not meet that last year, but we are working on improving our data so that we can track that better, and so that we can help ensure that the initiatives that we're putting in place is increasing that utilization rate.
Awesome. That helps. I said something very similar to the legislator that asked me, but he was in a very, I wouldn't call it a unique situation, but he represents a very rural district. And in particular, he says his constituents struggle quite a bit with finding direct support professionals in very, very rural areas of the state, which we have. Any thoughts on what we could do there? You don't have to have an answer. I thought it was a good something to ponder.
That's a great question.
Mhm.
And I think there's a lot of thoughts work, sort of the as we're developing programs, looking at technology-based services. What do we have available potentially there that won't work for everybody, right?
Yep.
Field is so unique in that, right? The skills are there's a whole spectrum of different skills. So definitely being able to look at where do we have those supports? How can we put those supports in place? And how do we attract staff into the more rural areas? Those are great questions that we do need to address.
Yeah.
And that's one of the reasons that we're running 4 different pilots across the state around direct support professionals, and our provider incentives are across the state. And we were really encouraging providers to be innovative with what they were doing so that we can learn from them what works.
I think just speaking from my own experience, right? I come from a very rural place. And I had the privilege of growing up with someone in my church. He had a developmental disability, he had Down syndrome. And I will tell you that in my very rural town, I don't think, and we had a group home too. Of course we do, because people with developmental disabilities are everywhere, and even small rural mountain towns like I have. But we didn't know what that career was that supports people with intellectual and developmental disabilities. And I think one of the things that's unique is, and it will take some time to come to fruition, everybody, but I think one of the things that you're putting the building blocks in place, Tina, this is the way I see it, is you're creating, this is a career. So kids in small rural towns like mine, who went to community colleges to be CNAs, right? They all went to be med techs or CNAs. Or they went into auto mechanics at tech school, right? Like these are honorable, wonderful careers that, folks in rural towns go for, as anyone can do anything everywhere. But it wasn't a career path. There was no such career path. And I think this interesting journey, maybe with the community colleges and offering other career paths for high school kids, I think is a really, really wonderful thing. So I promise you, like, I would have personally been quite interested myself, right? I am like many people in small rural areas. I got a degree in psychology because it was the closest thing I could figure out to a helping profession. It would have been really cool if there had been an associate's degree to work with people with developmental disabilities. So I'm like really excited about that we're developing
Thanks.
for everybody in rural and urban areas. I'm just
Well-
saying, I think that's a really tricky thing though, to think about rural areas.
Right. We're also including experience. So
Mm.
we're recognizing the importance of experience. So
Yeah, for
people who
sure.
are currently working as DSPs can use that experience moving forward as well.
Mhm. Yeah.
And doing some of that advertising, this is potentially a career for somebody that might be interested.
Yeah, yeah.
You know, I loved the work when I did it.
Mhm.
Most of the time, it's not always an easy job. And,
No.
and I think it's important that folks understand that too. It's not always an
Yeah.
easy job, but it is also a job that is so broad and unique. And it's not always the way people sort of have those expectations around it.
Mhm.
Sometimes what you're doing is you're a job coach. You're
Mhm.
helping
Mhm.
somebody in their work so
Mhm.
that they're getting to work on time and they have those skills and they're learning those skills. Sometimes you're taking someone to the grocery store because they want to learn to cook and you're supporting them in
Mhm.
learning how to cook, or you're doing community-based activities. It's not always personal care skills, which I think
Sure.
sometimes that is a sort of a misconception around that.
Oh, yeah, yeah, for sure.
A lot of these folks who require these supports don't always have behavioral challenges.
Mhm.
Sometimes they do, but not always.
Yeah.
So it's a really diverse group, and I think it's
Yeah.
really important that we put the whole person perspective out there.
Yeah, well said. No, thank you for that, Tina. Okay, so it's the initiative itself. It's a place where people can go find information. We give information because we want people to have access to services. We'll talk about more about services. Tina talked about we need a workforce. It's the underpinning of much of this, right? All right, so let me ask about something else. Here we go. So today's presentation actually was about the innovations waitlist, which is something that for most people on here, it's very near and dear to their heart, right? So 2 questions I'm going to ask you, whoever jumps in. First, what's the waitlist? But more importantly, how the heck does Inclusion Connects even help the waitlist?
Ginger, do you want that one?
Sure. So the innovations waiver, before we had 1915I, the innovations waiver was kind of it for services for if you had an IDD. And so you would get on the wait list and wait for those services. And it is a huge package of services. Well, the wait list has grown significantly over the years. We're about to put out the newest numbers, which are just over 19,000 as of June 30th of this year on the wait list. And those numbers are staggering. The way you come off of the wait list is you either get a slot into innovations, or you take yourself off, or unfortunately, sometimes people pass away or move out of state before they get a slot. So innovation slots only come available when people vacate a slot for some reason, or if the General Assembly gives us additional funding to add slots to the waiver. Right now, the waiver has 14,000, Tina, you're going to correct me, 400-ish slots.
14,736.
I knew she would correct me. So there are 14,736 slots. There were no additional slots added this year. So any slots that come available will be from somebody giving up their slot in some form or fashion. So the wait list continues to grow. We are generally adding 100 to 200 people a month onto the wait list. Yeah. But what Inclusion Connects is doing when it comes to the wait list is, one, we're standardizing it so that everybody that gets added to the wait list, we have the same information about everybody. And we can start to look for trends like around age, their needs, disparities if there are any, and making sure that we're getting the word out to everybody equally. And then we're also using that wait list to determine what do services need to look like in the future, and so that we can make recommendations. Not everyone on the wait list may need a slot. But we don't know that until we start to do some assessments and really looking at the needs of everybody. We also want to make sure that anybody that's on the wait list has access to 1915I if it's appropriate. They have access to other services that may be available through either state funds or other programs. So we want to make sure that they're getting some type of connection and some type of access to services while they wait for that innovation slot. Did I answer the full question?
Yeah, I'm just going to go ahead and add to, we have a dashboard. It's a really pretty dashboard and we stay on top of it and we update it. And a lot of the information in the dashboard is what we're using to sort of start delving into, like, where are we seeing those disparities and like what services are being used and accessed and those kinds of information. The members that are on the wait list are also people that we are looking at. If you do not have Medicaid, why do you not have Medicaid? I mean, maybe you're not eligible, and that's fine, because in order to have the waiver, you don't have to be, it waives some of the eligibility requirements. So you may be waiting, but also while you're waiting, you know, do you have access to all the services you need? Have you had the opportunity to access those services? And maybe the answer is yes, and you don't want services, and that's fine. We're not trying to force anybody. We're just trying to make sure that folks have the opportunity to decline if that's what they choose to do. So there's a great dashboard over on the Inclusion Connect webpage too.
If you are unsure if you're on the wait list, please contact your tailored plan. Don't just assume that you are. So make sure that you're getting in contact with your tailored plan. And if you are on the wait list, make sure that you're keeping your contact information updated so that when your name comes up, people can get you.
Yes. Okay. So, you guys haven't noticed because you've been talking, but I've been posting things in the chat. I posted a picture of that's a sneak peek, y'all, of the dashboard. And I was able to use the dashboard today and show it to legislators, which I think was actually quite helpful. Before we get off the dashboard for a minute and the wait list, right? And just one quick thing. Let's talk about the data itself for a moment. It is important, I think, that we're transparent about the data. We very much need to be. But what are we hoping to learn from the data? And is there anything we're planning on doing about the way we collect data?
So one, standardization is key, making sure
Okay.
that where we're getting the data, that everyone is collecting it in the same way. So
Okay.
we've been working on that for the last year.
Okay.
Now
Because
we've got about
the LMEs keep the wait list, right? And by and
Yes.
large, they collect some similar information, right? Similar, but some add other things and so, you know, and data, some of the data, let's be honest, is years old, right? And it was collected in old
Mhm.
ways, now it's collected in new ways, and
Yes.
maybe it was less robust and now it's more robust. I mean, so there's a variation in the data, all good intent. It's just, remember, we're talking about a data set that's very old. And we didn't just used to have 4 LMEs, right? I think when
Right.
I moved to North Carolina, there were still 23 of them. So not only have
That sounds-
we have old data, but we've have consolidated data. It's the LME's consolidated, right?
Mhm.
Okay.
We're at an exciting point right now where we've got a full year's data set.
Mhm.
And so now we can start recognizing maybe seasonal changes, seasonal trends
Mhm.
around like service provision. I know anecdotally, you can expect to see like around the holidays, the services utilization might go down.
Mhm. Yep.
But we'll actually have data to show those types of things
Okay.
so that we
Yep.
can plan.
Yep.
The other thing with the wait list, there
Mhm.
are all different ages, and DD is a
Mhm.
lifelong disability.
Yep.
And so we use it to plan what services not only do we
Okay.
need now,
Okay.
but what are we going to need in 10 or 15 years?
Okay. Do we know enough about the people on the wait list?
Not yet.
How are we going to find
Not
out?
yet. We have a work plan that does include
Huh?
looking and assessing everybody on the wait list.
There we go. Yep.
It takes funding. It takes a lot of coordination,
Mhm.
both with our tailored plans and with the
Mhm.
families, because we also don't want to
Yep.
create more burden for the
Yep.
families.
Nope.
Many of these families have told their story 100 different times.
Yeah.
So we want to
Yeah.
make it the most efficient and easiest.
Okay. Good. All right, good. So we talked about Inclusion Connects. We want people to get access. We talked about the workforce needs to be robust. Talked about the wait list and how we publish, collect the data, how we're working on making that more robust and meaningful. We want to be transparent. We want to plan for the system better. All right, very good. So you guys have said this, but what happens if you're on the wait list? Are you just up a creek for 6 years while you wait? What can you do?
Now that we have 1959, our goal
Okay.
is to definitely connect with all the people on the wait list.
Okay.
Making sure that those that are, so now 1959 is a little bit different in that you do have to have Medicaid, right? So you have to be
Okay.
Medicaid eligible in order to receive it. But also connecting, we know that the average age of the person on the wait list is 19. What that says to me is that there's a lot of children on that list. What types of services do we potentially have?
58% are under 21, 58%. Yeah.
What services are potentially available to our kids, right? Because
Yeah.
lifetime. So looking at
Mhm.
that as well and making sure that we're connecting folks and trying to make the system easy and accessible. So if you need to fill out a form or an application, you don't have to go searching for it. It's something that you should be able to go, this is the form that I need. You click on a button and you can go. If you need to contact your LME MCO, you're not sure which one it is, this is where you go to find where they are.
Mhm.
So again, it's part of making the system easy and accessible,
Mhm.
which it's not. We know that it's not. Everyone will tell you that it's not.
Yeah.
You look like you had a question, Kelly.
Oh, I do,
Oh,
I do, but I
okay.
didn't mean to stop your flow, Tina.
No,
I stopped
go ahead.
myself. Yeah. Okay, so 1959 is great. It's a very confusing term, is it not?
Mm.
So everyone that's on a wait list, is it up to them to just reach out to the LME and say, hey, I would like some services? Like, what are we doing to make sure like
So that's
people
part of this,
start asking, but also we start offering? I'm all for
right?
advocacy and asking, but are we offering? Are
Right.
we doing outreach? How's that working?
So that's coming. That's
Okay.
part of what we're working on adopting.
Okay.
Sort of figuring out who on the wait list, do we have their contact information for
Okay.
starters, which is
Okay.
why it's really important for folks if
Mhm.
you're on the wait list, please
Mhm.
make sure your information is updated so
Mhm.
that if the tailored plans are reaching out, if we're reaching out, ideally there should be annual contact with anybody who's on the wait list through
Mhm.
their tailored care managers,
Mhm.
through LMEs, through
Mhm.
whatever process. But we're working to standardize that process so that when someone says, what can I expect? It is the same for everybody.
Good, good.
Part of what we're dealing with right now is, like you said, there used to be a lot of LMEs and
Yeah.
they've been consolidated. We're down to 4 and there's lists
Yeah.
coming together. Everyone's handled a little differently. So that standardization is really important.
Yeah.
Especially as we're sort of working to make sure that everyone is contacted and everyone is sort of aware of what's available and has an opportunity to ask questions.
Yeah, good. Okay, good. So besides
And-
1959, what else could people get?
So there are some I hesitate to even say, but there are some finite state funded services that mirror
Sure.
the 1959 services. So there's community living and supports, there's supported employment and some respite and residential. Those again, those are finite and dependent on General Assembly appropriations that they give us.
Yep. Yep.
There are also other programs that may be out there that meet your needs. So for medically fragile children, there's CAP-C. For
CAP-C.
medically fragile adults, there's CAP-DA.
Yep.
For elderly, there's PACE. So there are other programs out there, and having IDD is not exclusionary. And it may help meet some needs that you may have and
Yep.
open some of that availability.
That's right.
And we want to make sure people know that.
Did you mention Taylor Care Management, Ginger?
I didn't.
Did
I
not.
didn't.
That's the
So,
number one. Surprise, not a
yes.
surprise. It's the number one service of people on the wait list, right? Which is good. It's a
So-
gateway service, right?
So if you are, if you have Medicaid and are with the tailored plans, then you probably have access to tailored care management. Tailored care management is, I mean, it's an amazing service that can help coordinate and link you to all sorts of services, not just
Yeah.
the IDD services, but your physical
Right.
health, your pharmacy,
Yep.
all of those different services. If you do not know that if you have a TCM, again, call your tailored plan and they will tell you if one is assigned to you. If you're anything like me, I don't always answer unknown numbers, so they may have called you and you thought it was spam. So definitely reach out to the tailored plans to find out.
All right, good. Yes. Taylor Care Management, and I don't mean to use jargony terms or whatever, but when I say it's a gateway service, right? Like, probably Ginger, Tina, all of us have been care managers at one point in time, right? Like it is important because the whole point is, let me sit with you, assess your needs, your goals, your strengths, and try to put together a plan. And care managers, when they're good, they can be amazing. And they can really help you, even if you are on a waiting list, right? Which is good. Make sure you're on the waiting list, right? They can also help you look at, especially if you're on Medicaid, get 1959 option services, go through the process, right? They can help you through the process. But they can also make sure you're using other Medicaid benefits. And as Ginger said, explore CAP-C, CAP-DA, PCS, occupational therapy, physical therapy, speech language therapy. There are other benefits. And they should be making sure you're getting good medical care too, and you have access to a primary care, preventative services, GYN care, dental care, vision, right? Because
Mental health.
sometimes we need help navigating those, right? Yeah.
Mental health, substance use.
Mental health. So, do you guys know percentage of the people on the waiting list who have Medicaid?
Believe it was 82%. was the
82%.
last number I saw.
And I got the data from Ginger, so I'm seeing the numbers. 82%, right? Okay. And do you know what percentage of people on the waiting list with all services? What percentage of people are getting services on the waiting list? If you look at all the services, not just the home and community-based services, right?
Mhm. Was it 54%?
Like 58%,
58.
right? So I want to say, yay, right?
Mhm.
Still want more, right? And that's
Mhm.
inclusive of anything on Medicaid, right? Not just home and community-based services, which is the
Kelly, just-
1959, right?
It does
It's
not
all
include
kind of things.
physical health.
Oh, wow. So that's just mental health.
Right, so it's
and-
mental health,
okay.
substance use, crisis services,
Ah.
TBI, IDD services.
Oh,
Physical health was not included in the
Okay.
numbers that we pulled.
so that number may jump up even
It
more
could be.
when we put in physical health. Okay, all right. But our goal is, y'all, our goal is to make sure that everyone who's interested has a care manager, right? That could easily beat 82%, right? And that we're helping to identify needs and get people into services. So that's a real goal. Okay, great. All right. So back to the questions. I veered off a little bit. So part of Inclusion Connects is Inclusion Works. See, we were clever that way, right? Inclusion Connects and Inclusion Works. So who's going to tell us what Inclusion Works is?
I will jump in on this one.
All
So I was really excited we were being clever with Inclusion Works and Inclusion Connects. Sometimes it gets a little confusing. So Inclusion Works is kind of that work within the Inclusion Connects program that is all about competitive integrated employment. And when I say that, it's pretty simple. We want to make sure that everyone has the chance to work if that's what they choose, earning a fair wage and being a part of a team of people with and without disabilities. The goal is really to connect people who want to work with opportunities, helping them go through assessments, get training, figure out like what do they want to do. Maybe they're starting there, like we all do, figuring out what skills they need, get that training, apply for jobs, navigate process, which is changing drastically as AI has been introduced and HR software, getting through those, making their way through the interview process, HR, navigating, learning the new job, and all of those social interactions that nobody typically teaches you how to navigate when you're starting a job. So Inclusion Works aims to streamline all of the supports that lead into that. And that includes the services through the Division of Employment and Independence for People with Disabilities, EIPD, formerly known as Vocational Rehabilitation. And then when they stop, that warm handoff into either state-funded supported employment or Medicaid supported employment through your tailored plans. For years, there was kind of a rocky, bumpy handoff in those, where a lot of times people weren't talking between those two systems as well as they could have. And Inclusion Works has been navigating that and smoothing out those transitions so that there's not that cliff between service systems there. And yeah, just helping people understand what their options are when it comes to employment and find and maintain employment. Go ahead, Tina. I see you.
I was going to say, and I have to add, because if you have not been over to DB 101 to help you understand the impact of working on your benefits, that is such a huge part of working, is understanding how many hours you can work or how much money you can make, and how that impacts what the benefits are that you already have. I think that is one of the things that often prevents people from wanting to get jobs, is because there's concern around it impacting those benefits.
Yes.
So that being built into that whole process, I think, is just really remarkable. And the buy-in from everybody involved in those workspaces. So, you know, with the EIPD and with the community and all of that collaboration, I think it's just really been remarkable getting that work going.
Yeah, we just recently launched our provider innovation initiatives, where we've got 4 providers that are actually going through an entire program with a national consulting agency, WISE, to revamp how they do supported employment. And really moving into that competitive integrated employment space, which is really exciting for them. And they're going to get incentives. And if any providers are on, we're going to have another round open up, hopefully very, very soon.
Great.
And there will also be opportunities for staff to earn certification that they will receive bonuses for as well.
Cool. So, Tina, how does Inclusion Connect support social interactions and activities? I actually really like that question.
So one of the things that we're looking at with the social interactions is helping people connect to things in their communities. The Community Living Guide, which has a lot of focus on housing, also provides some opportunities to look at different social activities. There's a lot of agencies, a lot of provider agencies that already exist in the community. And I'm going to go ahead and call out the Autism Society. They do a lot of work with peers and a lot of social activities and a lot of social opportunities. The ARC also does a lot of supporting those social opportunities. So the Community Living Guide that we have actually sort of works to draw that together and give people an opportunity to find the agencies that would support those social opportunities.
So I'm going to pause on that for a minute because I thought of one more employment question I wanted to ask. I'm sorry about that. I'm sorry for switching gears because I do think we're getting kind of into the third leg of Inclusion Connects, which is being in community, right? Housing, those social connections Tina was talking about, but let's stick on employment just for one little second. I will say something, I'll reiterate something Ginger said. I think it's important. Inclusion Connects is all about choice. And so we understand, and Ginger said this as well. When we look at both the innovations waiver and the waiting list, we've got a broad age range of people, life situations of people, and people have very different needs across the spectrum, and depending on the severity of maybe their diagnosis, right? If I can be all clinical about it for a second. So we appreciate that work can look and feel different for lots of people, and this is very much about choice. So just highlighting a couple of things that Ginger said earlier, just reminding folks, right? But we are super excited about competitive integrated employment. It's the right thing to do. Everybody has the right to work where they want to be respected, to be treated and paid fairly. Hard stop. Okay. But we know, and you said this, Ginger, but I want to put a fine point on it because I think this is kind of cool. Sometimes, right, in order to get a job, people need a service. They need supported employment services, right? That really helps. It can help find the job, coach the job, your job, you know, side by side shadow for a while, right? So how do you get supported employment? Like, do you have to have Medicaid? Do you have to have a waiver? Like, how can you get this?
That is a really good question that we probably skipped over. So the first stop is always EIPD. So going through your Division of Employment and Independence for People with Disabilities. Many people have already gone through that.
Okay.
But that's generally the first
And that's,
first
I
route.
love the name, but again, for just for reference, it's DBR, right? DBR, that's what we grew up with. The new name, I love it. It's a much better name, right? But I'm just saying, just so
Yes.
there's no confusion. Okay.
Yeah, sometimes you hear it called DVR, sometimes VR, sometimes voc rehab,
Yeah,
depending
VR,
on who
right?
you're
Yeah,
talking
VR a
to.
lot. Yeah, okay. So start there.
So you
Start there. They are
that's
the
your first stop.
employment experts, right? Okay.
So that's the first stop. And then let's say you need services beyond what EIPD provides, or let's say you secured a position and they're ready to back out. There's a transition. If you have Medicaid, you could either go the route of 1915I supported employment.
Okay.
So there would be a warm handoff there, and your tailored care manager would support that handoff. Or it may be that if you have innovations, you go through innovations for supported employment. And then there is a third option. There are some state funded supported employment supports out there as well. So you kind
So
of
we
go
believe
the,
in employment, and
Yes.
because we're covering it under any funding opportunity. And that's a good opportunity for people on the wait list. When you think about services, it could mean supported employment. Okay.
Yep.
Cool.
And let's say you get in a job and you absolutely hate it, because we've all been there, I'm
That
sure.
never happened.
You can always go back to VR or EIPD, or you can talk with your supported employment provider and be like, we need to do something else. So, and you'll
sure.
have supports for that.
All right, cool. Thank you for that. That let us veer back there for a second. Okay. So third thing, really important, which is community inclusion. Ginger or Tina, excuse me, started talking about community inclusion. So that Inclusion Connect sites and the Community Living Guide, which we'll talk about more, has really wonderful opportunities in the community.
Can I
But
mention peer
let's-
supports too?
Yeah, you did. I thought you did.
Right.
but-
Yeah, so one of the areas that we're working on really building out, and this is not actually my team, so I have to give kudos to the other team that's working on peer supports. We are working on developing a certified peer support specialist within the IDD and TBI space.
Yay!
I think is going to be huge when we start talking about
Yeah.
jobs and supporting employment
Yeah.
and helping people advocate for their
Yep.
own needs, and also find like different community activities and things
Yep.
that they want to do, and that kind of thing. So I think peer supports are going to play a really big role for us. So
Yep.
huge
Excited
huge-
about
huge-
that.
Yeah. I'm
Very excited about that. So the last thing is housing. Let's just get to the hardest one. If you've ever heard me talk about Inclusion Connects, everyone, I say it's the hardest thing. So why is it so hard, Tina? Why is housing so hard?
So, well, okay, so first, housing's expensive. I think that's one of the big things that we have to like sort of hurdle there. Housing is expensive. the funding, a lot of the funding mechanisms have their own rules around the housing. You can only have so many people, and you have to have, licensure and all of those kinds of things. And it's not, I think there's a lot of housing opportunities that are available that are not being accessed. Some of it also has to do with people don't necessarily want to live in very rural areas, or people don't want to live in very urban areas. And so the housing of their choice is not always available. So a lot of what we're doing statewide, not just within the IDD space, but looking statewide, is how do we provide different housing alternatives for folks to be able to access that still meet the HCBS requirements, the home and community-based services requirements, and then also still meet any licensure requirements, and is still affordable. And affordable becomes a real challenge, especially in the current atmosphere.
Can I back up just for a second on housing? Because I would just want to level set for the folks and for us too. Just when we're talking about housing, I think one of the things I want to acknowledge, and back to something Ginger said, is it's really complicated for all the housing reasons, right, that Tina was talking about. But also when you think about housing, we're really talking almost in some cases, a combination of both a place to live and services. And so they both have rules. The services have rules and the place to live have rules. And I think that's what makes it so complicated. So when we talk about housing and a place to live, we are literally talking about an IDD community, right? You can check me on this. We're talking about everything from ICFs, so intermediate care facilities. And it's important for us to have the conversation about how are ICFs functioning in North Carolina? What's their role? How are people in ICFs being well supported? If that's a choice for families, do we have them? Do we have them where they need to be? That's an important part of the conversation, right? So it's ICFs to people living in group homes with services, right? Because that's how they live in group homes, which is complicated. Group home and a service, right? People who live at home, right? But often the people that live at home, maybe a family home, right? Like parents, right? Or siblings. There's rules to that and the services that it takes to be there, right? And then there's people who may live in their own apartment, in an apartment with a roommate that also has some services probably that support that. Or they may live there with technology, which is another type of service, right? So it's this complicated, like there's many settings that we're talking about. And typically it's a combination both of the housing itself and how the housing literally is paid for, what it is and how it's paid for, and then the service that is also there and how it's paid for, right? So it's a lot, right? And that's when we're talking about housing, we're talking about all of that. And any one part of that's really confusing. Okay.
And then
So-
when you layer it all
Yeah.
together,
Oh.
it just adds more and more complexities. There are some really cool organizations out there trying to do some really innovative stuff in North Carolina.
Yeah.
And they are navigating all of that the best they can to move forward. And I
So
applaud
where
them.
are we? Where are we in our wonderful Inclusion Connects plan with housing? What have we done and what are we planning on doing?
So right now we have put out the community living guide.
Okay.
The other place where we have been, I don't want to say inserting ourselves, we have been welcome there. So we have a statewide housing strategic plan. It's a 5-year strategic plan.
That's part of Olmsted department, right? Olmsted, yeah.
Yes, through our Olmsted office. And then that plan also has regional plans that our tailored plans are putting together. IDD is included in all of those. We actually have an IDD person sitting on all of those committees, all of the reviews to make sure
Good.
that IDD is
Good.
not forgotten.
Good.
The other thing that we're doing is trying to make sure that when people come to us with questions about housing, we're getting them connected to the right person. Making sure they know if you're asking me a licensure question, I'm going to connect you with somebody at the Division of State Health Regulations. Is that DHSR?
Yep. Health Service
because,
Regulations.
Health
Yeah.
Service Regulations. I
Service.
always screw that one up.
Yep.
Making sure you're connected there. Or if you have a question about a waiver clinical coverage policy and how that impacts housing, we're going to get you connected to the right place to get an answer.
Okay. So we have a community living guide and it describes this web that we said, housing and housing programs and housing options. Services, service programs, service options. Do all those things work perfectly?
No.
Do we get to change the housing rules?
We're working on trying to make it more accessible. Is it easy? No.
Mhm. How about the services? How much control do we have over how well the services are working or not? A lot is the answer. The answer is a lot.
A lot.
So-
A lot.
Yeah.
Right. So no, I feel very passionately about that if you can't
Yeah.
tell, right? Like there are things we can do with housing partners and there are programs that we can advocate, like HUD. There need to be more HUD slots, right? Right.
Mhm.
But services, supported living, group living,
Mhm.
this is where, again, this is where our sweet spot of control actually is. How do we make those, how do we listen to the community and say what's not working about those services and how do we make them better? And how do we do better with technology? Because we're just way behind y'all. Not everybody. Some people are knocking out of the park, Tula, but you know, we got to move forward in technology, right? Okay. So, okay, we've laid out to the best of our ability in the housing guide, kind of like here's housing options and programs, here's service options and how you get them. There's also things in the guide too, Tina, you mentioned about community engagement and interaction. And I know there's things about transportation and other things in the guide too, right? Because it's, you know, we want to make sure that we have a lot of resources in the guide, right? Okay. What else am I missing about the guide?
There's a section on financial.
So
So
stuff,
if
good.
you need some financial support, there
Okay.
is also a section on like immediate housing. So if you find yourself in a
Okay.
crisis and are
Okay.
in need of immediate support housing, there's a section around that.
Okay. So I have 3 minutes and about 3 more questions.
Okay.
Is that all you're going to do? Inclusion
No,
Connects team.
no,
What else are you
absolutely
gonna
not.
do to make
So-
housing better?
So here's the thing. This is all a work in progress, right? We've been at this for a year and a half, 2 years now. And so, we're in the process
Everyone
of
needs to hear that.
Huh?
Everyone needs to, I just need to pause. We have been working on it for 2 years. And we're not done yet, right, Tina?
No.
I'm just pausing because
No.
what I'm saying to you is there's commitment here, y'all. Okay.
Mhm.
We're
So-
not gonna drop it and move on to the next thing. Go on, back to you, Tina.
But here's the thing.
But-
So
Mhm.
we very frequently, and we say it a lot,
Yep.
but by all means, if we're missing something, bring it to us
Yeah.
and point it out.
Yeah,
This is not
Mhm.
static work. I mean, this is
Nope.
why we're checking all of our links quarterly. This is why we're making sure everything is current and updated. All
Sure.
of this is something, right? Because it serves no purpose
Yep.
if you go and look and it's not working. So
Right.
we're staying on top of that, but it's
Yeah.
all work in progress.
yeah, but then what?
And I also want to put in a plug. We have an entire work plan that is laid out on Inclusion Connect's website
Mhm.
that goes through, these are the activities and this is how
Okay.
we are moving forward.
Okay,
We wrote it in very accessible language. We wanted to make sure that people understood what we were doing and why.
Mhm. Mhm.
And it, again, is not static. So we're reviewing
No.
it as the environment changes, as opportunities come available,
Mhm.
we update it.
And I will not give a timeline on what I'm about to say, right? But part of what we wanted to get something helpful out now, which is the wonderful, helpful housing guide in the website, right? Pulling together resources, trying to help people navigate all of that. I just said there are things that we can actually control in that, right? Like making services better if they're not working. Supported living's not working, we gotta make it better, right? Self-direction's not working, we gotta make it better, right? Just do. But is there anything we can, well, I'll just say it, because we're low on time. We also, remember we talked about the waiting list data? That's data. One of the things we hear about from families all the time is, I'm worried about where my loved one is going to live in the future, right? So part of what we are working on, and it's going to take some time, y'all, to understand is what housing is actually available to people versus what is needed and projected to be needed. And we have to do our best to map that out, right? And that means a whole lot of things. What services are we missing? What kind of housing are we missing? And that's across the board. Everything from ICF to group homes to family homes to apartment homes and the services. So part of it is honestly understanding what we have, where the gaps are, and being thoughtful of a plan to help fill some of those gaps. And that is kind of one of those projects that will take forever. So I'm going to say something and then I'll end with the question because it's done. What I'm going to say is, I should have said it at the top, but I think everybody on this webinar knows. Inclusion Connects is the name of a vision and a program, has 3 parts, it has a big old work plan. It keeps us accountable for moving forward in the IDD system here. You can't say I want Inclusion Connect services, and we don't provide services and we're not providers, right? Inclusion Connects is the programmatic vision, but we work, of course, with our wonderful LME MCO partners, right? They contract with providers who provide services, right? So it's a system. And it's our job to partner with all the parts of the system, consumers and families to listen and learn, providers to provide the right services, and for us to fix the regulations and the service definitions, right? With LMEs around funding or more funding and how they regulate and oversee the program. So we're one big family in this, but I don't want folks to leave this webinar thinking, I'm going to get some Inclusion Connect services, because, you know, we're the state, we don't provide services, but we try to have a comprehensive vision and program that we're working on. So if people want to know more about Inclusion Connects, Ginger and Tina, how are you going to help them learn more about it? How are available are you to organizations and families that want to know more about Inclusion Connects?
We have a handy dandy slide to pull up that
All
has our
right.
contact information. Tina and I both listed our email addresses. You're welcome to reach out to us. You're welcome to send questions to the generic email box. We're pretty good at being responsive to folks, and happy to meet with people and talk through to hear. We also encourage you to go to the website, dig around, poke some holes, tell us what we're missing. Come
Yeah.
to our advisory committees, because if you don't tell us our blind spots, we don't know them. So we invite you to come to those. And then we also wanted to include LME MCO contacts. Again, verify you're on the wait list, update contact information, find out if you have a tailored care manager, all of that. So,
Thank you, Ginger. Thank you, Tina.
thank you, Kelly.
Thank you to our
This was great.
interpreters. Yeah.
Thank you.
Thank you all for joining us here tonight. And we are very excited about Inclusion Connects, but we thank you for all the partnership. And I think Ginger said something really important. These are our goals now. These are the things we're working on now, but this is a commitment and it's a living and breathing vision. And we do want your feedback, because when we accomplish this task, great, then we can move on to the next thing. So keep telling us what the next things are so we can keep working to build a really strong, inclusive system here in North Carolina for folks with IDD. All right. Thank you all, and I hope you have a really good night.
Thanks, y'all.
Bye.